Hello and welcome to the Spinal podcast. My name is Dr. Brian Joves.
I'm Jason Kung.
And we're back, guys. Thank you all for listening. Thank you all for sticking with us while we have gotten our feet back under us and getting the podcast up and running again. Today, Dr. Kung and I just wanted to kind of come on and talk a little bit about everything that's been going on in the world of neuromodulation. So we are currently in the middle of 2023, and this year has been a very loud year for neuromodulation. And I think there has just been some topics that we felt were necessary to kind of digest together and hopefully digest for all of us as a community as we're trying to really get a bearing on where things are and hopefully where things are going. So Dr. Kung, I think one of the first things that, I'll kind of give a little tease, guys. We're going to eventually get to the Cochrane study, which is probably the biggest thing that's been happened so far this year. But let's start with some lighter fare. So there's been a lot of talk so far this year about implantable pulse generator size. Dr. Khan, what are your thoughts on IPG size as we start seeing that as a part of the neuromodulatory wars, as well as something that I think a lot of the companies are starting to think about from a marketing perspective?
Yeah, my notes, the first line I have is IPGs, IPGs, IPGs. So that's just like you said, it's a hot topic right now. A lot of new devices currently being approved by the FDA, either approved or in the process of. And one of them, talking about size, smaller isn't necessarily better. It seems like Abbott is at least suggesting that might be the case, but it's not just about the size, right, Dr. Joves?
Yeah, it's never just about size.
So the recharging requirement for the new Abbott IPG is pretty remarkable from what they're saying, right? The recharging burden, or the amount of how frequently someone needs to recharge it, it may even go down to 4 or 5 times a year, or maybe just once a month. I mean, it's some pretty remarkable stuff.
Yeah, and so for anybody who is paying attention on the YouTube channel, holding up two of the two smallest IPGs that are currently on the market. So the Medtronic Intellis and the Abbott Eterna. And so they are by dimensions the smallest. Abbott is a little bit smaller in terms of its height and its width. The Medtronic is a little bit thinner in its profile, and so when you kind of look at total volume, I think the Abbott device by total volume is just a little bit under the Medtronic Intellis battery. But then, obviously, then you go from there, and there's actually quite a big jump. I remember seeing somebody post the kind of volume of the IPGs, and as you kind of step up from these two to Boston Scientific, and then all the way up to Nevro, which has the largest volume IPG. And so just thinking about, does a smaller battery lead to decreased infection risk, decreased risks for the patient of irritation from the battery? And I think anybody who's done this long enough has seen patients that just really get irritated by the battery, or the battery can actually cause some discomfort for our patients. And so that's one of the questions that we're all trying to figure out as we have the technology now to be able to create these amazing batteries that are smaller, that charge quicker and require less time on the charger than particularly the things when I started that patients would have to charge every day, sometimes for a couple of hours a day to be able to use those. And anybody who's even been doing this for beyond 10 years probably can say that they remember a time that people were charging exponentially more than that. So I think it's a very interesting conversation that we're having.
Yeah, it's all about trying to make it as easy for the patient to get the relief, right? So if they have to constantly be thinking about kind of having this fear of running out of the battery and having difficulty with the charging pad, it can lead to just kind of losing faith in the device and then eventually just not using it. So I think it's really exciting that we're starting to think more about the technology, and in addition to the waveforms, to try to help people get better relief. I will say that with the Abbott device, the Eterna IPG, these stated claims of the recharge frequency is based off of a standard burst setting that they have listed out there. So, if there's any deviation from that, the patient's needing some sort of recalibrations, I would assume that the recharging times would vary, but certainly excited to see how this plays out in the real world.
Yeah, I think that was actually one of the first questions that I asked our Abbott rep was when I saw the advertising material that said as few as 5 recharges in a year. I was like, how many patients do you have on the settings?
Mm-hmm.
For everybody out there, her answer was 0. I know I didn't have any patients that were on those settings. So yeah, obviously, part of it's marketing, but even if it's not 5 a year, but it's 1 a month or even a couple of months, yeah. Obviously those are huge improvements compared to what we've seen for patients in the past. And so, I think these are steps hopefully in the right direction. As you said, it makes it easier for patients to be able to access the therapy and just not lose faith because of a battery that gets in the way of the actual technology.
So if anyone's been listening to the news lately or listening to the radio or watching on TV, everyone's talking about AI. Isn't that right, Brian? AI, everything.
There's a lot of it.
I think we'll be
everything, right?
Yeah, AI podcasts. Eventually, we won't even need doctors to be talking. We can just have 2 ChatGPT plugins talking to each other.
They might be more
plug in all of our notes.
That'll be the sad thing, is if they can actually recreate the magic of interpersonal communication.
But so we bring that up now because Nevro has a new IPG coming out. They call it the HFXIQ. And basically that's going to be helping to do a lot of the reprogramming, and even the reprogramming is done within the app that the patient has on their phone. So I think that's another big leap, is that there's no longer going to be just the controller, but there's going to be a phone with an app on it that can basically recommend new settings for patients or help them troubleshoot their current stimulator to try to get them better therapy.
Yeah, I think it's interesting, right? I think, as we were kind of preparing, you brought up like not having to have, reach out to somebody else to kind of make these daily changes to be able to figure out how to optimize what the patient's experience is with the device, and something that actually kind of feeds back and is able to make some of those changes on its own. It's a really interesting thought process, and it's obviously very new. This was one of the biggest things that they brought out at NANS, and I think there's a lot of people talking about it because AI is a hot word. I think the cynic in me, because I've got to have a good bit of cynicism, is whenever we look at things that are hot in the media that become marketing ploys for companies, just wonders how useful this will actually be on an everyday basis for patients. Thinking about most of the patients that we have that, particularly ones that I think find good relief from a couple of different programs that don't necessarily may or may not actually need something that's constantly evolving the way that their therapy is being delivered. I don't know. Yeah, what are your thoughts?
Yeah, certainly it's how it plays out for a patient that has chronic leg pain that uses some combination of paresthesias when they're out doing stuff versus paresthesia free when they're at home relaxing. How is that going to change that? Are they going to have to flip their own routine to kind of go with the new stimulation? I'm sure there's got to be, sure, as it rolls out, it's going to be something that will be customized to each patient. But I think at least having the option to, hey, it's 11 o'clock at night and it's feeling a little bit off, versus kind of waiting until the next day to call the company rep or contact one of us that, hey, just go into the app and just punch in some things that are going wrong or feeling off and possibly getting a new program that night. I think that will be a really good thing.
Yeah, no, I agree. I mean, I think that aspect of it, right? The being able to just decrease the number of touch points that the patient has to have, so that way, I think as we were talking about with the battery, right, the less things getting in the way of the therapy of the patient, that hopefully will lead to more happy patients with more successful outcomes. So I'm really interested to see how this kind of plays out in the real world. I haven't personally had experience with this as of yet. I haven't talked to very many people that have, a large enough end to really have a feel for what it's doing for patients. Yeah, it's one of the fun things to watch over, the coming couple of years, seeing how that really interacts and affects patients. One of the things I think, also that has kind of come along, we talked about betters and AI, and there has been some kind of a little bit more discussion, I think, on primary cells. Primary cells being a non-rechargeable battery as opposed to a rechargeable battery, which has, I think, for all intents and purposes, become the standard at this point. Is a rechargeable battery, but figuring out how we, now that the batteries are so much more powerful and the technology that is being utilized is so much more advanced, are there ways to be able to allow patients to not have to have any charge burden at all, right? Forget about, like we were talking about earlier, about decreasing the recharge burden, but if there are actual ways to make it so that patients can have, essentially no recharge burden, where it's just them in the therapy, and you get to see how well people do without having to deal with the device. I think one of the things that you had talked about earlier was that, historically, this is something that we've left for a slightly older population, maybe less technologically advanced, didn't want to interact with it, didn't want to deal with it.
Right.
But I don't know, I mean, what are your thoughts if we start thinking about that as potentially an option that's been presented for other patients too?
I mean, if that becomes the standard, I think it's going to be widely accepted. No matter if you know how to use a smartphone or not. I mean, everyone's busy nowadays. You have some people have multiple jobs. Some people have a really busy primary job. They have families at home. Finding time to recharge may seem like, oh, just take some time out of the day, but there's so many other things to juggle. So if there's a way that we can have it so that, like you said, the therapy's in, make some changes to the programming if you need to for certain situations, but if not, otherwise you don't need to recharge it. It's on, and once it runs its course, we switch it out. I mean, that would be I think that would be the standard if that becomes widely accepted. Yeah,
I think it's interesting. I mean, I think I'm probably fairly similar to a lot of other people. I don't use primary cells very often. I did just actually, I just did a post-op check on a patient that we put a primary cell in, but the main reason was because she's 83, and so it just seemed like it was the best option with talking with her and making sure that everything's going to be as easy as possible to get her the relief that she has. And it's, I think it's nice, and we can still run some complex programming on a device like that and be able to, which is different than before. I mean, I think even go back 5 or 6 years, we couldn't run very complex programming on any of the primary cells. And so, we have a DTM program running for that patient right now. And for all intents and purposes, I have hope and believe that that's going to last her quite some time, and she's going to get some good relief from it. But yeah, I mean, I think if, I think the theme so far today is the less things that get in the way of delivering this therapy to patients, the more acceptable it's going to be for patients, the easier it's going to be for them to really get the most out of it, right?
I don't think we can not talk about, since you said DTM, we're going to have to mention at least the Inceptive IPG from Medtronic. That's looks like their aim with that is to also incorporate in closed loop stimulation into this new IPG. And from what I heard, it can also incorporate in DTM as well. So I think this is still being worked out. They're doing a study in Australia right now, feasibility study. But that is also on in the pipeline. Yeah.
And for those who are listening who may not have kind of heard us talk about neuromodulation before, I think this is the area, this is the reason why so many of us are so excited about our field, right? I mean, we're literally doctors who get to sit at the kind of bleeding edge of technology, right? We're talking about AI, and we're talking about new IPGs and different ways of utilizing electricity to be able to change people's lives. Like, it's a pretty amazing thing, And when I first got exposed to pain medicine, I guess it was 15 years ago at this point. I mean, like, it was a part of things. Like, obviously, the North study had been published, and like it was there, but it wasn't to the extent that we're seeing now, and where we're kind of literally like talking about multiple different devices, multiple different things going on, a lot, so much that's coming to be able to help our patients, and then we end up getting slapped in the face with a paper that I think most of us in this field have not received very well.
I would agree. that is a very nice way of putting it. Yes.
I think
there's been some.
Yeah, I mean, it's been probably the biggest outrage that I've seen out of pain docs probably ever. I mean, I wasn't a pain physician when those Friedley articles were being published about epidurals not helping patients with stenosis, but I mean, this feels even bigger than a solo article. And so the Cochrane review, which is very widely respected and accepted within medicine as being a very prominent voice, if not possibly even the gold standard for many avenues of medicine, came out with a review that was concluded with the statement, data in this review do not support the use of spinal cord stimulation to manage low back pain outside a clinical trial. Current evidence suggests spinal cord stimulation probably does not have sustained clinical benefits that would outweigh the cost and risks of the surgical intervention.
Wow.
What were your initial thoughts when you first heard about it, read it? I think we'll dive obviously deeper into why this is so frustrating. But what were your initial thoughts when you saw it, when you read this?
I mean, it was shocking disbelief, right? Just from all the studies that have been coming out, over the last even just 1 or 2 years, and then seeing this, I had to read it a few times and just make sure I was reading the correct thing. It just didn't quite seem real to me. So yeah, just very, very confused, shocked, and then I was just trying to gather a way to dive into it myself and look into it. Yeah. What about you?
I mean, the same, right? I mean, it blows my mind that when anybody who does what we do or pays attention to what we do or has listened to any of our podcasts where we've talked about the vast amount of data that's been published, these huge landmark studies that have been published, from North, we've already talked about today, through any of the other big trials, Senza and Sunburst and the DTM study or the Vogue study, how you can look at that data and believe that spinal cord stimulation is not of benefit. Granted, okay, this is for low back pain, right? That's what they're
right.
That's what this is targeting. But it was, I mean, it felt almost as crazy as reading the headlines that there was a neuromodulation company that was giving fake leads to physicians to implant.
Right. I had to read that article.
We'll probably don't need to touch on that because that's a crazy story for water cooler talk. But that's, I mean, like when I read that article, I felt like somebody punched me in the gut. And I think that was the initial impression of reading the at least the first time through the abstract, and obviously reading the headlines for the Cochrane review.
Yeah.
But so let's, I think both of us obviously disagree with this because that's why we're shocked. Obviously, we probably wouldn't use these if we didn't think that they were actually helpful for patients. But yeah, I mean, maybe we can kind of start going through some of the reasonings why we don't think that this makes a lot of sense and why it's so hard, because my understanding is Cochrane doesn't allow for updates on their reviews for at least a period of time. I don't know what that period of time is. I believe it's years, but it is going to be a period of time that the Cochrane review does not believe that spinal cord stimulation is appropriate for low back pain.
Yeah, so just as a quick review for the study itself, it was done out of Australia, and it was a meta review looking at several thousand trials comparing, and their criteria for inclusion was comparing spinal cord stimulation either to no treatment or to placebo. And they wanted to assess the effects, including benefits and harms, of spinal cord stimulation for people with low back pain, just like you said, Brian. And the conclusion you already mentioned, that basically they didn't support it and didn't have any sustained clinical benefits that would outweigh the costs. So the trials that they looked for were through some of the 5 largest databases: Medline, Central, Embase, clinicaltrials.gov. They searched up to June of 2022. And out of 4,776 trials, they found 113 full text papers, which all related to 58 trials based on the titles and abstracts. So from the 58, they then eliminated 19 as they deemed that the comparator was not relevant. So of note, they excluded trials that compared spinal cord stimulation waveforms to each other's, spinal cord stimulation versus revision surgery or versus other sorts of surgical interventions. And they eventually came down to 13 trials that were eligible for inclusion up to June 2022. There was one trial that was then added later on that was published in October 2022 after the initial search criteria time frame. So I think we'll leave that off to the side for a moment, but that's just one thing that we found interesting, as well as a lot of the other docs in the community, that they just decided to add kind of one trial on later on.
Yeah, I think everybody listening can interpret that as they please, but generally strange to change your inclusion criteria for a later published trial.
So they eventually came down to 13 trials, 699 participants with low back pain. 9 of the studies were looking at tonic stimulation. 5 of them included high frequency. And the 6-month data that they felt was relevant came from one study. So, the exclusion of some of these landmark trials, like you said with the Senza, Sunburst, DTM, they excluded it because it didn't fit their inclusion criteria of it, spinal cord stimulation being compared to no treatment or placebo. Like a lot of these landmark studies were looking at the comparisons of a new waveform to tonic or continued medical management. So it's, you lose all that great data that has been really the bedrock for stimulation, especially with the advent of with paresthesia-free waveforms. So, you're cutting out a lot of good data there. It not necessarily placebo controlled, but just because it's not placebo controlled, I would argue it doesn't necessarily mean that it's bad data.
Yeah, and I'm gonna obviously agree, but I think maybe the one learning point for our specialty is that because so many other specialties utilize the comparison to placebo as the gold standard, where I think for so long, and probably just because there are so many different options to treat these patients, that the comparison to placebo hasn't really been what we've generally considered to be the gold standard, or at least the norm for a lot of these clinical trials, right? And so I think obviously we're gonna get into bashing this study more, but I mean, as a learning point, I think hopefully we can learn that to really have our data accepted by medicine at large, like they still are going to always have this gold standard of versus placebo.
Right.
You know, the double-blind randomized controlled comparison versus placebo, which always, you know, obviously when you're doing an implantable device, the question is how do you do a randomized double-blind controlled study versus placebo?
Right.
You actually implant a placebo device, or you know, which has its own risks and can cause its own trouble for patients, and so on and so forth, right? So not that we need to dive into that, but I mean, obviously, I think that is something that from everything is a learning opportunity kind of standpoint that hopefully we as a field can start to try to figure out, right? How do we create these studies that are going to be wider accepted, not just within our field or not just within, you know, spine surgery at large, but also within medicine that has these different not beliefs, but a different way of judging clinical data.
Yeah, just because the FDA doesn't require placebo-controlled studies for device approval, and just because it's expensive and difficult to run these placebo-controlled trials, as you mentioned, with putting in, what do you do, like putting in a dummy lead, dummy IPG, just because it's difficult doesn't mean that, you know, our field can really rise up and try to figure it out. I mean, you know, there's a lot of us out there, and we can hopefully over time figure some way to create a study that fits more in line with other specialties with their placebo-controlled trials.
Yeah, sorry, didn't mean to interrupt your flow there, but that was it was like, you know, trying to figure out how to make a silver lining out of something that I think most of us would say is a pretty dark cloud.
Yeah, so a lot of the longer term data, meaning more than 6 months, did kind of get interpreted or was pulled from this study from Hara in 2022, in October of last year. So that one was I think it's, you know, we have to talk about the study when we talk about the review. I just feel like, you know, a lot of the key points, even in their summary, was directly pulled from this. And they compared, I mean, there's a whole series of other issues with that study, and I don't really necessarily need to go into all the nitty-gritty for that, but there were some issues with that one. And
I feel like dissecting that study is like
its own
itself, which
yeah,
stay tuned. That'll be the next one, because yeah, that, I mean, I remember reading that study when it came out, only to feel, you know, kind of double shocked that it became such a big part of this Cochrane review. But yeah, I agree. There's a lot of challenges, right?
Right. And as we mentioned, this one came out in October of last year versus when their initial search was going up to June. So they, it was just added on later on, which seems a little bit strange for, you know, such a large review study like this to then just add on the study outside of their inclusion window.
Yeah. And and so, I mean, when you now are basically utilizing essentially, you know, 2 studies really to make an entire Cochrane review off of, and the study with a longer term follow-up that was extremely flawed. Just to surmise what the future podcast will be telling you. I mean, you know, you have a device that's implanted that runs a waveform that was never trialed on the patient. That waveform that was never studied anywhere else before. A trial with a massive attrition rate, and a trial that the requirement for trial to perm was significantly different than what we use in the real world.
Right. 2-point improvements in the numeric rating scale, which I guess if your pain is a 4 and it drops by 2, then that's 50%. But you know, I wouldn't be putting in a stimulator for someone with a pain level of 4 to begin with.
Yeah, and so, you know, I mean, a very flawed trial that I think got plenty of flack when it was first published, that then becomes the kind of bedrock that Cochrane decides to base their thing on. One of the things that you didn't bring up that I think has always irked me about any time that I read something that's kind of really trying to tear down things that we do in our field is that nobody was a pain doctor that was a part of writing this.
Yeah, I think correct. I think the main authors were not. There was an acknowledgement to a position in, I believe, somewhere in Utah, but they were not an author of the study.
Which always, I mean, I think it's, to me, as somebody who does this, who cares deeply about our patients, who is constantly searching for ways to be able to help the patients that are coming through, to have somebody who doesn't do what we do on a regular basis, trying to critique what we do, I think I've always found challenging.
Yeah.
I mean, I think everybody. It's supposed to be about the medicine or about the science of it, which is, I think, the reason why they did it. But it wholly takes out just like the actual understanding of what it is that we do.
And that kind of leads into just everyone. I think everybody out there has bias. I mean, I'm biased, you're biased, the authors are biased. But to have some other folks on the table, at least talking about the study and writing it together, which obviously much easier said than done, but that would have it wouldn't have hurt as much, I guess, reading it, knowing that some of the authors also were in some field related to pain management, that they were on the, had a say in what was being published at the end.
Yeah. So I think that to me is a challenge. And so it's hard, right? We have to digest this now because now this is a Cochrane review that has been published. And, we were talking all of these things about ease of delivering the therapy to patients. I mean, this is going to be, at some point, I fear, this is going to be a big detriment to being able to deliver appropriate treatment to our patients, right? I mean, like, I as of yet, I have not seen or heard much change as far as, authorizations, approvals. I mean, I know there's always kind of changes that are going on. There's a few states that I think they were already in the works in terms of changing their policies, but nothing that I've heard of as of yet that is specifically changed because of this Cochrane review. But I mean, that's a real concern that this might become something that truly changes our ability to help so many of our patients.
And then at the end, we just we'll have less tools to help our patients coming in, and it's going to be at the unfortunate for the patients.
Yeah. And I feel like we're now ending this episode on a real down note. We started off with so much hope and expectation and all this fun about the future, and now we're kind of getting all Debbie Downer about, will this really change what we're able to do for our patients? Jason, give me something good. Take us out on a positive note. So we, obviously we've got a lot to look forward to. We just have to figure out how to make sure we can keep being able to provide this for them, right? Be able to get this approved by continuing on.
Yeah. I think with the new technologies coming out and, some of the new stimulation companies that we didn't mention possibly coming to our shores, there's going to be more indications that'll pop up over time. There's been even a newer study that came out this year. I think it was from a few months ago, but it was looking at treatment for neuropathic pain. And we're not going to get into that. It was by Fatima, a study from Pakistan. It did show that spinal cord stimulation did have superiority over other treatment options at the 6-month follow-up. So I think we're just starting this. I don't want to call it a battle, but it is going to be somewhat of a conflict within our specialty, and trying to figure out how we can get the message out that spinal cord stimulation does help with folks with lower back pain. But in addition to that, the other indications out there for spinal cord stimulation it's very exciting, and there's lots of things to look forward to for that.
Yeah, I think you're right. I mean, there's so many things that we're just kind of scratching the surface on in ways that neuromodulation is going to continue to affect people's lives, and is going to be able to bring so many more options for patients. We didn't really talk about it, and we will at some future date. I mean, now diabetic peripheral neuropathy is on label for 3 different companies now, and so I mean, that's a whole sector of the population that didn't used to have an on-label treatment that insurances really looked at as a viable option to be able to help them. And so now it is, right? So like you said, I think as our job is just to continue to provide good tools and hopefully good study that will continue to support as we keep expanding and keep trying to do more and more to be able to serve all these people that are living with more pain than they'd like to, and are having their quality of life and their functional abilities depleted because of it.
Well said.
All right, my friend. Closing thoughts for anybody out there?
Read the study. Take some time. Make your own conclusions. Obviously we have our thoughts here. I wasn't hiding anything, but read it on your own and see what you think. Talk to your colleagues about it. Talk to your non-pain medicine colleagues about it. I think that's another important thing. You try to engage the community and get feedback and do some education and learn some yourself, and it'll help the field as a whole.
Yeah, I love that. Yeah, read the study. Reach out to us. Let us know what your thoughts are, and see if you think that we got any of this wrong or that we're misinterpreting things. Best place to find, I think, either of us is probably LinkedIn. If anybody wants to reach out directly to us. Otherwise, yeah, please share this. Share your thoughts, particularly if they agree with our thoughts, with your community, with the primary care docs out there, so that as they're starting to go through and they're seeing these Cochrane papers, and Cochrane saying that they don't believe that spinal cord stimulation is effective. And the problem is, it says not effective for low back pain, but the headlines are always just read not effective, period. People are going to start having questions about this therapy, and so get out there and talk to everybody about what we believe the truth to be, what we believe our studies to say.
Right on.
Everybody, you guys be well. Stay tuned for those legal disclaimers, and we'll talk to you next time.